timely, insightful, discussion and analysis of economic trends and markets. From Southern California to Sacramento, featuring business and political leaders, unique field reports. From Orange County and the campus of Chapman University, this is the Chapman Business Report.
And welcome back to the Chapman Business Reports, our weekly look at business, the financial markets, and a special focus on the regional economies and trends of Southern California. I'm Pete Weitzner. I head up the broadcast journalism program here on the campus of Chapman University, actually a couple of blocks west at the Dodge College of Film and Media Arts. Just behind us, that spinning object you see there is the Global Citizens Plaza, dedicated a couple of years back by the former Secretary of State Colin Powell. A special show on this occasion is devoted entirely to healthcare, the future of healthcare delivery in this country, and a terrific guest to give his insight into that. Dr. Rick Afable is the president and CEO of Hoag Memorial Hospital Presbyterian in Newport Beach, one of the finest regional hospitals in the country. And Rick, let's dive right into it. Before we get to the issue of healthcare, so much to talk about. Quick background on yourself, and then let's just talk quick in a macro sense how we got to this point where we needed this major transformational change known as the
Affordable Care Act. And healthcare reform.
And healthcare reform.
Yeah.
But yourself, your background.
Sure. Thanks, Pete. It's my pleasure to be here with you today, and I'm very happy to be here on the campus of Chapman University.
Your daughter is a student.
My daughter is a senior here, and she's had a tremendous education. So thanks to Chapman, and thanks to President Jim Doty for the great job that Chapman has done with my daughter and with this community. A little bit on me. I am the President and Chief Executive Officer at Hoag. You had mentioned Newport Beach. We also have a facility in Irvine, so we have two facilities and many outreach areas as well. We are the largest independent provider of healthcare services in Orange County as a hospital and hospital system. I'm a physician by background, so I've been an internist and a geriatrician for my entire 30 years in healthcare. Actually spent 17 years in private practice and academic practice. Spent most of that time in Chicago. I was actually faculty at Northwestern University, and I understand you're a Northwestern graduate yourself.
Yes, I am. Went to Medill.
Yeah, that's great. So got into the management side about 12, 13 years ago. I've been at Hoag now for 6 years. Came here specifically to be the president and chief executive of Hoag to essentially transform what was at that time a great community hospital into a regional and nationally recognized health center, and we're well on our way to doing that. A big part of our intention and a big part of the board's goal when they sought out a new chief executive was the vision of moving Hoag from a community hospital to a regional leader.
What does that entail?
Well, it entails having a better understanding and a better recognition of the healthcare needs of this community, not only for the current time being a hospital ready to treat sick people, but also for the future, and to be doing planning and allocating resources to plan for the future of this very large community, Orange County. And by doing so, as we begin to plan for and then assist the community in managing healthcare so that this community can thrive from a healthcare standpoint, Hoag then, like Orange County, becomes a leader nationally, because truth be known, Orange County is truly a microcosm of this country. You know, with 3 million people here and the diversity and the nature, the socioeconomics of this community, as goes Orange County, could go this country in many, many areas, and we believe healthcare is one of them.
Speaking of healthcare, so in March of 2010, we get past the Patient Protection and Affordable Care Act. Many have referred to it as the biggest transformational change, certainly in healthcare, since Medicare, 1965. Is it fair to say the biggest reason that necessitated, at least those who, and everyone agreed that we have a big problem in healthcare delivery, back in '65, we spent less than 3% of the budget on healthcare. By 2016, we'll spend 30%. Is that accurate?
That is what the predictions would say, and many would say and believe that that is not affordable. You know, other than national defense, healthcare is the #1 expense of our country, and that's just on the governmental side. If you add in the private side, you know, we're talking about a tremendous expense. Now, healthcare is important, so we want to spend money on the health of our communities and the health of our citizens. The question is, what are we getting for that expense, and what are the trends of that expense, and is it affordable? And those are the issues that were and are being attempted to be addressed by governmental action, the most notable of which was the Affordable Care Act last year.
How did the cost part get so out of whack?
Yeah. So that's a very complex question, and it doesn't afford itself a simple answer. Suffice it to say that healthcare, the modern era of healthcare truly began in the mid-60s with the onset of the government entering the healthcare arena through Medicare and Medicaid, which we call Medi-Cal here in California. And the design of healthcare payment came from traditions and actions that were occurring in the 60s and 70s at a time when healthcare was transforming, when technology was developing, when healthcare was becoming very expensive. In order to continue to develop, there needed to be, let's just say in the 70s and 80s and maybe even in the 90s, new ways of thinking about how healthcare could be paid for. And actually there were many attempts to do so, and many will remember the Clinton administration's attempt in 1992 and 93 to reform healthcare payment. That failed, and failed primarily because there wasn't an appetite in Washington, D.C.
We're not unique
to do that.
in having most people get health care through their employers. We're not unique in that, are we?
We're not unique, but I would say about 50% of the developed countries in the world have primarily governmental programs. So in Sweden and Denmark and Norway, and then just north of us in Canada, and then in the UK, those are governmental programs. Those are not employer-sponsored programs.
You operate a private hospital. Are you
Yes.
predisposed? One would think you're predisposed to not want that.
Well, we're not predisposed to not want that. That's a double negative. We want that. The point to be made is what we want is equity. What we want is a system that allows for all citizens to receive the care that they need, but it has to be done in a way that's affordable long term. The problem with the Affordable Care Act, as it has been enacted last year, many would say in a very unilateral way, that then led to the enactment of a plan that is built and structured around payment, is that we never really got to the care part. So it says Affordable Care Act, but the care is really not addressed in the legislation that was passed. It's all about payment.
And payment.
It's all about payment, and so the problem is that we want to expand health care, that we want to make it affordable, we want to make it fair and equitable to all, but what we've done is said we have to do all of that and we have to spend less money. That just doesn't add up.
And add in 2014 35 million people to the system. The highlights, you break it down very simply. It's three parts to the Patient Protection and Affordable Care Act: insurance reform, access reform, and payment reform. Let's go by one.
Okay.
What is it? Because very little of this has been implemented, and we all know some is being challenged. I think in just a few days before we record this, a court struck down the long-term care part of this, but we'll put that aside because who knows, even if the Supreme Court were to strike this down, it is law, and that still might not mean it's a fait accompli. You operate on the assumption this is law and it will go forward. So let's start with one of the three big planks, insurance reform. What does it entail?
So insurance reform is probably the least controversial of the three elements. And insurance reform is essentially designed to ensure that individuals are not harmed by the business of the selling and the operating of the business of insurance. I use a little example which helps a lot, which is if you have auto insurance, your insurance company will insure you, but if you have too many claims and you have too many accidents, they're going to drop you. Well, health insurance is exactly the same today. And what that means is that if you get sick or if you have a medical problem, the truth is that in the United States today, insurance companies can either rate you up so high you can't afford it or drop you completely. So probably the key element of the Affordable Care Act as it was enacted last year, which again was very non-controversial except for the insurance companies, and was and is held as something that everyone generally would want, is that people can no longer be dropped from their health insurance just because they're sick And by the way, when they move from job to job, their insurance has to go with them. And they're allowed to do that because a lot of people were afraid to change jobs because they were afraid their insurance was going to get dropped.
They would just get that COBRA plan for a month or two and...
Well, not only that, but if you had diabetes, for example, and you changed jobs and you went from Chapman to UCLA might say, well, we're not going to insure you because you have diabetes. And so therefore, you're not going to move in your job. That becomes illegal with the onset of the Affordable Care Act, and that's phasing in now over the next 2 years.
They may not have liked that aspect, but insurance companies generally, their insurance company stocks, for instance, have risen because I guess they like the fact that they're going to get 35 million new customers.
Yes, so the second plank, as you put it, or the second big bucket of the Affordable Care Act is access reform. And so there are little bits and pieces that are coming into place over the next 2-3 years, but the biggest element of access reform is that effective 2014, 35 million people of the 50 million people today who are uninsured, 35 million people will become insured, meaning that they will have either a state-sponsored or an employee-sponsored health plan that they then can use in order to have access to care. And so the problem with the uninsured today is while they can still get care, so it's important to recognize it's not as if people are dying in the streets because they don't have access to care. They can always go to the hospital emergency room, they can always go to places to receive care, but what they can't get is good coordinated preventive care or care services and health care services because they don't have insurance. And so effective January 1, 2014, 35 million people will be insured. The part that is very controversial about this, and that will be addressed by the Supreme Court either later this year or in the spring of 2012,
the mandate,
is the individual mandate, which says just like insurance in California, auto insurance in California and most states, in the United States, the Affordable Care Act will say that every person who's a citizen of the United States must have health insurance. And by the way, it's not going to be given to them by the government. They're going to have to buy it if they can afford it. And so the controversy and what the Supreme Court is going to take up is, can the government mandate that you or I must buy something whether we want it or not? And so that individual mandate will be a big deal. But the way the law states right now, every individual must have insurance by 2014. And if they can afford it, they must buy it. And if they can't afford it, the federal government or the state governments will subsidize to make sure that they can receive it.
And recently recorded a show, as we often do, with Essie Adibi, our economist, talking about jobs. I suppose this might be a good part of it, to enforce that mandate. As we speak, I believe, the government is in the process, federal government, of hiring 60,000 people primarily to enforce that mandate.
Yeah, so you think about the insurance systems in the state, just think about taxes. People who don't pay taxes, how many people are working for the IRS to go find people who don't pay their taxes? So how many people is it going to take to police, if you will, the 330 plus million people in the United States to be sure that everybody has health insurance? It's a huge infrastructure that's going to be required, which adds costs to the system.
Third plank is payment reform. What's that all about?
Yeah, so if we think about the first two, which is everyone will have guaranteed access to insurance, and oh, by the way, everyone must have insurance and must receive it, either they have to buy it, get it from their employer, or get it from the government. That's all going to cost extra money, right? 35 million people coming into the system, receiving care. That's a good thing. We want access to care, but the problem with that is that we have to figure out a way to pay for that. And the third plank is payment reform, which in quite simple terms is a multi-trillion dollar, a trillion-dollar reduction, multi-billion-dollar, hundreds of billion-dollar reduction in cost for the government in health care services. So, and this is where the difficulties come up with the Affordable Care Act. So we want to add 35 million people to the insurance rolls, and we want to reduce the cost to the government by as much as $1 trillion over 10 years. That doesn't add up. The only way that can happen is if somehow providers like Hoag Hospital or doctors or anyone who's providing care is willing to take a lot less payment for the services they provide today, or we figure out a better way to care for the entirety of this country, a way that is less expensive than we have today.
Rationing.
Yeah. Well, no, not so much rationing. I'll just say better care. So rationing would be what I would say is the superficial way of trying to solve this issue. That's not going to work. I don't think the people of this country will accept rationing. And I know for a fact that the providers of health care in this country, meaning doctors and hospitals, will provide care for a lot less payment than they are right now. And the reason is because they can't. Because half the hospitals in California today are losing money. And so how would it be possible that doctors and hospitals would begin to accept lower payments for the care that they're provided? They're going to be wanting at least a similar payment to what they're receiving now. Certainly would hope that it wouldn't be less, but yet we're going to have 35 million people coming into the system. The solution, and I'm sure we're going to get into it in a few moments, for me at least, is we need to provide better means of care, methods of care. We need to reform health care, not health care payment, and that's the part that the Affordable Care Act forgot.
We'll get into that in just a bit, but look into your crystal ball. How is this going to play? Let's forget the legal part. Let's assume it stays the law. How will it play out? Because you think it has to play out.
Yes, it will play out in some fashion. So assuming for the moment that the individual mandate does go through, and assuming for the moment that most of the elements of the Affordable Care Act that are now law are implemented over the next 3 years, and actually they will be implemented over the next 5 years, but most of the significant changes to healthcare delivery will happen in through 2014. What we're going to have is a tremendously increased number of people, 35 million is the estimate, who will have and expect access to quality care. We don't have the infrastructure to take care of 35 million more people. There aren't enough doctors, there aren't enough hospitals, and there aren't enough healthcare providers in this country, and they're maldistributed. So they're not in the inner city and they're not in the rural areas. They're in the suburban areas. And so that maldistribution is going to lead to difficulties in how this thing actually plays itself out. Not only that, but without health care reform, meaning different ways to care for people, the costs are going to go up. It's just simple math, right? 35 million people are added to the rolls. Nothing has changed as far as the cost of care. There's attempts at reducing the payment, but the costs still remain high, and therefore the costs are going to go up, and it's not going to work. If I'm looking in my crystal ball, I think 2015 and 2016, we begin to recognize that it is not holding down costs, that access is not as good as we thought it would be, and that those who are in a position of influence and power at that time will be looking for changes and adjustments, more than adjustments, major changes to the Affordable Care Act and healthcare delivery in order to bring the costs down, bring those under control, and to give people access to the care that they thought they were going to have because they had an insurance card, but it's just not available because it doesn't exist.
As you've pointed out, many have, it's not the first time we've looked at this issue. You mentioned Bill Clinton, I think it was called the Healthcare Security Act then, but many economists, people in the medical field have been looking at this for decades. And there's not one solution. I mean, there's various parts. Some say let's get away from the third payer, but there's no incentive for the customers to be judicious. What are a couple of elements that you would have liked to have seen in this reform?
Sure. So I think that as we talk about health care reform, meaning reforming the ways by which care is delivered, we needed to allow for alignment among all of the participants, the stakeholders, if you will, in healthcare delivery, so that there was clear benefit that would accrue and occur to each of the participants as care is delivered. So for example, right now you could say that we have 4, maybe 5 major stakeholders in healthcare. We have patients, we have doctors, we have hospitals, we have insurance companies, and we have employers. Right? So we have all 5 of those that are participating in healthcare delivery. And then if you wanted to, you could add the government, but let's keep them out for the moment. What happens in our current payment system is that as doctors and hospitals are paid for their services, and let's just use the term make money, if you will, that's a cost to the insurance companies. As patients have increasing deductibles and co-payments, when they see doctors and hospitals, that's a cost to them. And then for employers, when insurance companies are making money, that means the employers are not doing well, or vice versa. And so what we have is silos that have been built up over decades. This all emerged from what I called the modern era of healthcare through the mid-60s with the onset of governmental payments. And it has emerged and developed, in a very dysfunctional way over time, but we've been willing to accept it as a society because even though the costs were going up, it always was as if someone else was going to pay for it. So it was someone else's pocketbook that we were delving into.
So you're a single payer guy. You're in that camp.
I definitely am not a single payer guy, but thank you for raising that. because I don't believe that the government in and of itself has the capacity or the capability to manage health care.
It doesn't have to be the government. It could be the individual.
It could be the individual. So what I am is somebody who believes that there should be a regional strategy or a regional approach, because I do think healthcare is local. And I think every regional area, whether it be a city or a community or a county or even a state, should make the decisions for themselves of what will work culturally for their area. So you may have heard that the state of Vermont is just now putting in legislation that will cause a single payer system run by the state in Vermont. So what they're saying is culturally that works for them. And if they're willing to try it and to make it work and to go for it, I think they should be allowed to do that. I can tell you for a fact in Southern California, that would never work. The individuality, the decisions that people want to make on their own behalf, the fact that this is a small employer community, Southern California is a small employer area, all leads to me in a significant number of individual decisions that individuals want to make as far as and companies want to make. And so I think we need to have a plurality approach here, not a single payer. And so Southern California is different than Vermont, which is different than New York, which is different than Oregon, where I think that there are different ways. So I think let's concentrate on the care delivery for localities, and then let the localities determine how it is that they would work out a balanced system economically and clinically that would provide for the needs of that community.
And of course, before Vermont, I've heard that Massachusetts implemented their own local reform.
Yes.
The then governor, now running for president, Mitt Romney, says for one, with its individual mandate, they have the lowest percentage of uninsured children in the nation. And I guess obviously that's a good thing.
Absolutely true.
And I'm sure you looked at how it's working out in Massachusetts. Sure. How is it working out?
So in 2006, the Romney plan, I'll call it, which was universal health care available to all citizens of Massachusetts, was put in place. It is true that they have the lowest number of uninsured in the United States. They also have the highest level of healthcare inflation in the United States. And they meaning the leaders of Massachusetts, will be very clear in telling us, the rest of the country, that what they put in place, which was payment reform, now requires care delivery reform in order to make the economic changes that were made work. And so what they're going through now, and they're putting in managed care systems, they're putting in bundle payment systems, they're putting in a whole host of what I'll call innovations in care delivery. That's what we're going to be doing in 2015, 2016, when what has been enacted as law, the Affordable Care Act, which is about payment reform, just the numbers don't add up.
Another real area of concern I know you've expressed, and really it's one of the main selling points of the U.S. healthcare system is innovation. I mean, it sure seems like most of the blockbuster drugs, inventions here in Orange County, it's medical instruments, in San Diego, it's biotechnology, yes, come out of this country. Mm-hmm. And you worry about innovation going forward under healthcare reform.
Well, you would worry about innovation from a cost perspective. Then again, there can be and there should be improvements to cost as innovation occurs. So I wouldn't be worried about innovation in technology or drugs, because they should improve care going forward. Now, in the short run, they might be more expensive, but in the long run, they should improve things. The innovation that's needed, and when I talk about health care reform, care delivery reform, that's the innovation I'm talking about. I'm talking about innovating in ways that cause alignment between the 5 stakeholders that I mentioned previously, a change in the laws that prevent those 5 stakeholders from actually working together and collaboratively to improve care and reduce cost. So there's an assumption in our legal system that when 5 big businesses like the stakeholders I mentioned, which includes patients, are in collusion somehow, that's a bad thing. So collusion can be collaboration if it's well designed and if it's well thought out. And that's the kind of healthcare reform that I'm talking about. We need innovation. This is what they're doing in Massachusetts right now, which is that they're causing innovation in care delivery. They need to get better care for populations with lower cost. And you can't do that by doing the same thing over and over again. You have to innovate. And so they're doing new and innovative things. We should be incenting organizations like Hoag and the other great health systems here in Orange County to innovate and to do things that will cause better care at lower costs. And then when we do something that works, we can then share it with the rest of the country.
I'd love to ask you about some specific ideas on those incentives, but as we all know with the topic of healthcare reform, we've only scratched the surface. And so I'd love to have you back and talk further. There could be some significant developments as far as the Healthcare Affordable Care Act, and so hopefully you'll come back and do that. But we thank you very much. Dr. Rick Afable is the president and CEO of Hoag Memorial Hospital Presbyterian, one of the top regional hospitals in the country. Thank you very much.
Thank you, Pete. My pleasure to be here.
Appreciate your insights. And my thanks, as always, to Jeff Cole, class of Chapman 2001, Jeff Cole Productions, for putting on Chapman Business Report, and his crew, Ryan Westra, Haley Quarteroni. Back again next week with another look at business, the financial markets, and a special focus on the regional economies of Southern California. I'm Pete Weitzner.
Funding for this program was provided by Chapman University.